Good afternoon, and thank you so much for joining us to this webinar presentation about strategies and tools to support equity, safety, and quality in virtual care delivery. For this Lunch and Learn webinar, we've convened a panel of experts in primary healthcare quality and virtual care delivery from the Alliance for Healthier Communities, Healthcare Excellence Canada, Canada Health Infoway, and Ontario Health. They'll present an overview of their organization's virtual care resources, and they'll help us understand how these resources can complement one another and be used together when planning and delivering virtual care. They've got a wealth of information to share, so let's dive right in. Next slide, please. So we'll start by covering a bit of housekeeping. This will be quick because I know you're all Zoom pros by now. We are recording this webinar, and we will share a link to the recording along with the slide deck later this afternoon or tomorrow morning. It's Friday, so more likely Thursday, yeah, tomorrow sometime. So do watch your email for that. There will be a Q&A and discussion period at the end, so please submit your questions in the Q&A panel, and feel free to start typing those at any time as soon as you think of them. We'll ask for them on your behalf, and we'll do our best to group them thematically. We've also set it up so that you can comment on or upvote each other's questions, so feel free to do that. If there are a lot of questions, we'll try and prioritize the one that seemed to be on a lot of people's minds. If you would prefer to ask your question out loud, you can do that. However, just use the raise hand function that will unmute you when we call on you. But as always, please remember to mute yourself afterwards so that we can keep the background noise to a minimum. Now let's start in a good way by acknowledging the original stewards of the land where we are virtually gathering today. We recognize that the work of the Alliance for Healthier Communities and our members takes place across what is now called Ontario, on traditional territories of Indigenous people who have lived here since time immemorial and have deep connections to these lands. We further acknowledge that Ontario is covered by 46 treaties, agreements, and land purchases, as well as unceded territories. We are grateful for the opportunity to live, meet, and work on this territory. Ontario continues to be home to vibrant and diverse Indigenous communities who have distinct and specific histories and needs, as well as constitutionally protected and treaty rights. We honor this diversity, and we respect the knowledge, leadership, and governance frameworks within Indigenous communities. In recognition of this, we commit to building allyship relationships with First Nation, Inuit, and Métis peoples in order to enhance our knowledge and appreciation of the many histories and voices within Ontario. We also commit to sharing and upholding our responsibilities to all who now live on these lands, to the land itself, and to the resources that make our lives possible. My name is Catherine, and I'm a settler. I live and work in what is now called Toronto, or formerly Toronto. It is covered by Treaty 13 with the Mississaugas of the Credit. It is the traditional territory of many nations, including the Mississaugas of the Credit, as well as the Anishinaabe, Chippewa, Haudenosaunee, and Wendat peoples, and it is now home to many diverse First Nations, Inuit, and Métis peoples. Next slide, please. So you can see our panelists up here on the screen. We've spotlighted them for you. Maybe just give a quick wave when we say your name. We have Dr. Jennifer Rayner. She's Director of Research and Policy at the Alliance for Healthier Communities. Morenike Akinyemi, Senior Manager of Stakeholder Engagement at Canada Health Infoway. Jessie Checkley, Senior Program Lead at Healthcare Excellence Canada. Dr. Kevin Sampson, Family Physician at East Wellington Family Health Team. And Dr. David Kaplan, Vice President of Quality at Ontario Health in the Clinical Institutes and Quality Programs. Next slide, please. So we will get started with Jen presenting about virtual care research at the Alliance for Healthier Communities. So Wendy, if you can, perfect. And Jen, take it away, the floor is yours.
Thanks, Catherine. So if we could go to the next slide. I'm going to be going backwards a little bit because I wanted to go right to the beginning of the pandemic when all of the Alliance members, which include community health centers, nurse practitioner-led clinics, Indigenous primary care organizations, and a handful of family health teams, offered many services virtually. So they made sure that everyone got primary care, chronic disease management, palliative care, counseling. But as we were rolling out virtual care, we really recognized significant gaps for certain people, both with those who required in-person care, but also around the significant issues around digital equity. So who had access to technology, and what sites started to do was organize phone drives. They solicited corporate donations. They reallocated funds to purchase phones and data plans, because as we all learned, virtual care was inaccessible for many people living in poverty, and also those that might have relied on accessing Wi-Fi at libraries and coffee shops. So I realize this is seems like ancient history now, but I think so much of what we learned during COVID is still so relevant when we try to apply it to anything as we move forward. So, as I am going backwards a little bit, but I feel like it's so relevant, and some of the lessons we learned are still very, very applicable. So if we go to the next slide. What happened right off the bat was centers started generating lists of clients using their electronic medical record, and then assigning those folks to appropriate staff members to call. So at that point, as everybody knows, people were being redeployed into different roles to ensure that people most at risk had wellness check-ins. So during those calls, providers checked in with patients, identified and addressed their needs, and tried to do this preemptively, as well as answer questions about COVID, but also really check in about anybody that was vulnerable. So they looked at people who were maybe experiencing greater isolation, had food insecurity. They did mental health and substance use check-ins, or just really these regular routine check-ins to make sure that folks had ongoing contact on a weekly or bi-weekly basis. So next slide. So what also happened is they quickly redesigned all of their health promotion and social support programs to be virtual. So this included yoga programs, exercise programs, seniors programs, LGBTQ programs, supportive care chat rooms, cooking demonstrations, you name it, it got changed into virtual programming. And what people were finding was that this was actually increasing access to programs. And as we're going to hear throughout this presentation, people really sort of started to twig on how this might be a really good option to continue providing some aspects of care. So as I just talked about, we did this rapid shift to ensure people had access. And along with the health promotion programming increasing access, they also noticed that within primary care and all of the interprofessional team care, that this was, potentially a really good thing. It sort of fast-tracked us into providing virtual care, which you'll see with some data, we weren't the fastest on the uptake with that. And they really felt that maybe, this could be a good way to get people in for things that were most appropriate. It might increase access for some folks. But they really recognized that there was significant equity gaps. And they also wondered what they could do to better understand what worked well. So they really wanted to understand, how it worked, with whom it worked best, what services were most appropriate, and when virtual care was best. So they, I got a few phone calls during those early days and said, Jen, we'd really want you to do a rapid research project so we can ultimately improve the care we're providing and understand how we can leverage the information so we can continue to do this as we move forward. So we go to the next slide. We quickly designed a study and got ethics approval. And what we did is we used the quadruple aim as a framework, because we really wanted to understand how this impacted outcomes, how it might improve patient experience, looking at sort of the population health outcomes. So, we wanted to make sure people were all being served that needed to be served. So that equity lens was so important for us. And we wanted to understand the provider and the client experience to ultimately make some recommendations that were really real and practical for the providers and the organizations. So we had several different data collection methods. We were able to rapidly put out an organizational survey. We really wanted to understand variation between centers and what the characteristics of those organizations were. So we wanted to look at rurality, how long the sites had been operational, what sort of staffing structure they had, what services were offered virtually, what platforms they used. Because remember, this was really early days. We wanted to learn. We wanted to understand the steps they took to transition services virtually. And finally, we wanted to understand the challenges that they experienced in implementing virtual care, and really look at an equity lens to figure out which populations experienced the most challenges or had any sort of access gaps. We also had a really rich source of EMR data. So for folks that know the Alliance, we've got a data warehouse, and all of our EMR data flows into this data warehouse. So we were able to link sociodemographic data of the clients and look at who's accessing virtual care versus in-person care, look at the types of services they got, the types of providers they saw, and for what conditions. So that was a really rich source of information. And finally, when we look at that quadruple aim, we really wanted to hear from providers and we wanted to hear from clients. We wanted to know about their experiences with virtual care. Did they experience any technical difficulties? How did it feel that it impacted on the quality of care? What they felt were the limitations and benefits. Did they prefer the phone or a video consult? And what was the interest in sort of future delivery of care in this way? So I'm just going to sort of go on to the results, and because we've got just a short amount of time, but at the point of this project, 50% of the organizations responded that they were reasonably prepared to offer virtual care, which we were pretty surprised at since it was such a rapid transition. They did stress the major implementation challenges, which I think are still very real today. So, some of the northern and rural areas experienced some Wi-Fi and IT issues, security and privacy concerns were raised, which we've heard in many other research projects looking at the transition to virtual care. Funding for technology is a pretty huge thing, and we're still experiencing that. So to be able to use some of the video modules with our EMR, that costs money, and just staff readiness, which I think some of the tools we're going to hear about later today will really be helping. The populations who experienced the greatest barriers were people with mental health and substance use issues, people experiencing homelessness, newcomers, and people living in poverty due to some digital equity issues. And again, what we found was that's why a lot of people just stayed open, which you'll see. So you can see the rapid shift here to virtual care, but at least half the visits within the CHCs specifically were provided in person still. So there were so many clients that still needed to come in. And you'll notice that most of the visits were on the phone. And when we get to the provider and client feedback, you'll see that everyone really liked the phone, which I think is also being seen in other studies. Many providers said that they often started the visit on the phone, but would switch to virtual if they were required to do so, being, based on the issues being addressed. So that may also be a bit of an artifact due to the data collection methods we used. So what did we learn? Next slide. That phone was the most frequent used modality. I think this is also what we've seen in other projects. We're sort of hoping that video encounters would be used more. And we did find that some interprofessional team members did use them. We heard such really innovative stuff. So diabetes educators and dietitians were going around people's kitchens, using the video options. Mental health therapists and social workers also really liked the video. There was really no significant difference between rural and urban centers. So a bit of a myth buster there for us. Like we heard there was a lot of differences, but there wasn't anything that was reported or seen in the data. And there was really no difference in the socioeconomic data between difference in modality. And we think that might be because centers did so much on digital equity by providing phones and data to folks that needed it most. So just quickly, I've got one more slide just to go over the results of the interviews. The provider experience, I think, again, consistent with what we've learned in other projects, is that providers really miss the inability to read body language. Now, maybe if we used the video more often, that wouldn't have been such a barrier. We've heard this over and over again, privacy concerns and distractions. I think the providers were a bit concerned about where people were having these interactions. The providers really felt they could provide at least 50% of their care virtually, and the majority would offer virtual, but they really stressed the importance of having that initial visit for in-person, really to build the relationship with new clients. Client experiences, very similar to the provider experiences. This was often the first time they'd experienced virtual care. They felt that the access issues, some were really benefit in the sense that if you had mobility issues, they were able to have an interaction with a provider regardless of their ability to get to and from the organization. It avoided traveling time, paying for transportation and childcare, so it saved money. They avoided busy waiting rooms, and they said they were less likely to miss appointments. So there was some efficiencies to this. But the clients did say that there was some technical issues trying to use the video, so they really preferred the phone. And again, they stressed the same fact as the providers did, that they really wanted to build that relationship with their providers for that first appointment. So So finally, just there's a couple of papers we've written that we're happy to share with you. And we also, with all of our work, we're trying to make this really meaningful. So we did this project because, centers asked us to really find out what worked. So we provided 2-page summaries to the providers and organizations, really trying to share the results so they could learn and improve the work they were doing. And as well, we provided a client report so people could understand how their work was demonstrated throughout the project. And we really wanted to provide feedback to the clients that so graciously gave us their time in participating in this project. So early work, but I think, again, I think we're trying to leverage this as we move forward to continually to provide access to care. So thanks so much.
Thank you so much, Jen. And now we'll move on to Healthcare Excellence Canada and Canada Health Infoway, who are going to share about the Clinician Change Toolkit that they created. So Morinike, Jesse, and Kevin, the floor is yours.
Thank you so much. My name is Jessie Checkley. I'm a settler, and I'm joining you today from Winnipeg, which is located on Treaty 1 territory. It's the traditional lands of the Anishinaabe, Nanu, Ojibwe, Dene, and Dakota, and is the birthplace of the Métis Nation and the heart of the Métis Nation homeland. Thankful to be with you today. So next slide, please. So we're going to be talking to you a little bit today about the Clinician Change Virtual Care Toolkit, which was a collaboration that began in 2021 between Canada Health Infoway and Healthcare Excellence Canada. Next slide, please. For those of you who may not be aware, Healthcare Excellence Canada is a new organization with a relentless focus on improving healthcare with and for everyone in Canada, formed through the amalgamation of the Canadian Foundation for Healthcare Improvement and the Canadian Patient Safety Institute. We're an independent not-for-profit charity funded by Health Canada, and Canada Health Infoway is an independent not-for-profit organization also funded by the federal government. Infoway inspires, informs, and mobilizes Canada healthcare stakeholders toward a shared and reimagined future where digital health helps create a better and more connected experience with patients at its heart. And they work with partners to transform the health system, including governments, provinces, territories, clinicians, patients, industry, and healthcare organizations. Next slide, please. So I think we've got a poll we're going to put up for folks just to get a sense of how many of you might be aware of the Clinician Change Virtual Toolkit at this point. So I'll ask you to take a second or two to just respond to that. I know that I can't vote on it, but I will look to folks at the Alliance perhaps to share what our results look like.
So we're going to give you 15 more seconds and then we'll close the poll.
Okay, so lots of this tool will be new to many of you, which is great. So maybe at this point I'll pass it to Morinike and ask you to tell us a little bit more about the toolkit itself.
Great. Hi everyone. Next slide, please. I'm excited to be here today. My name is Morinike Akemi, and as mentioned earlier, I'm a senior manager within our stakeholder engagement function at Canada Health Infoway. Really excited to be here today to speak to you about our Clinician Change Virtual Care Toolkit. I'm going to go through a few slides to focus more around the context as to how this toolkit came to be. I will try to go through it quite quickly because I want to give Dr. Sampson enough time to really go into the nitty-gritty of the toolkit. So for context, in 2021, Health Canada provided us funding for a number of initiatives, including what was called the Change Management Program. And really what this program was looking at was realizing that the pandemic had started a year prior. People needed to adapt quickly to provide safe patient care, which included mostly scaling up virtual care. And so people did that as they did that quickly, and there wasn't really enough time to like pause and say, okay, what are the best practices? Are we sure we're optimizing this? So what we're trying to do with this program is to create that reflection point, to go back to clinicians and say, what is working well? Are there still gaps? How can we support you? What type of tools and resources will be helpful? And so that's what we did on the change program. We had one focused on clinicians as well as patients, but for this conversation today, I'll be focusing on the clinician work. Next slide, please. And so in order to come up with the toolkit, we spent a few months in the research and discovery phase, really to understand where the gaps are in order to identify priorities. So we did things like an environmental scan, and we looked at tools that were already available in Canada because we didn't want to reinvent the wheel where it wasn't necessary. We also looked at tools from the US, the UK, and other countries. We did focus groups, interviews with clinicians as well as support staff. And when I say clinicians, I mean the broad spectrum of healthcare providers. So that includes pharmacists, allied health professionals, etc., really wanting to ensure that the toolkit will be relevant across the board. And our primary focus for this work was around primary care. And so based on all of that information, we synthesized it and then identified 3 priority areas. I won't go too much into detail with this because Dr. Sampson will go through that. But the first area was around appropriate use of virtual care. So essentially, when do you know exactly when to use virtual care and what modality do you use when? The second one was around quality and safe virtual care interactions. That is recognizing the fact that virtual interactions are quite different from face-to-face, and what type of resources will be helpful to support that in terms of ensuring that we're optimizing that clinician-patient relationship, but also things like how do you make assessments virtually? And then the last one was around the use and optimization of virtual care services, which included things like determining the right tool to use. Do you use Zoom versus Microsoft based on your context? How do you ensure that you're taking into consideration the right privacy and security requirements? How are you ensuring that you're appropriately embedding it into your workflow? So those were the 3 areas that we identified as priorities. And so what we did was we created what we call the preliminary toolkit. So essentially, we curated the tools that we had identified across these 3 different categories and then provided it to a number of teams to test out for 6 months. So next slide, please. So what we did is we had the preliminary change toolkit and worked very closely with Healthcare Excellence Canada. They led this part of the initiative, which was the design collaborative, where we brought together 25 teams across 10 jurisdictions to test out the preliminary change toolkit. And the intention was to get feedback from these teams to say what was working well, what needed to change, what needed to be adapted. We also used the opportunity to really provide tailored coaching for the teams to really increase their capabilities and capacity as it relates to providing virtual care. Based on the input we got from the teams, we then revamped the toolkit and released the first version of the toolkit by the end of May of 2022. With that, I will hand it over to Dr. Sampson to go through the toolkit.
Excellent, thanks very much. I think before I start, I need to declare that I am a virtual care enthusiast. And so you'll have to put up with some of my passion, but hopefully some of you will be more enthusiastic by the time the talk's done. So thank you for that. Virtual care, how can we do it better? I'm going to go over how the Clinician Change Virtual Care Toolkit can really help. So much has happened and been happening with virtual care. It's been challenging, especially as a clinician, to keep up with what's possible and with best practices. We've gone from figuring it out as we go to being overwhelmed with all the guidance and recommendations that have come out. There's a lot of redundancy, and it's hard to separate evidence from opinions. And this is where the toolkit really helps. It's a clinically oriented, practical summary of key points to consider, and it's all presented in a concise and accessible format. I'm going to present a high-level overview of the toolkit and show you how useful it can be, whether you're just getting started with virtual care or looking for how to do it better. So next slide, please. I think I'm unmuted now again. Yes, the toolkit covers appropriateness, use and optimization, quality and safe interactions, and equity. It also includes a virtual care evaluation guide and a well-selected list and summary of virtual care tools and resources. Next slide, please. The first main section, as we said, is of the toolkit is on appropriateness. When is it appropriate to use virtual care? It's challenging because there's so much to consider, but the toolkit breaks this down really nicely. So clinical considerations, of course, are a very important factor. Are there symptoms or concerns that would require an in-person assessment? Would the patient's relevant medical information be available for the visit? What's the quality of the current relationship with the patient, and would it translate well to a virtual visit? These are just a few of the clinical considerations listed in the toolkit. It also gives a lot of good examples of situations that would typically be more suitable to virtual care and those that would not. Patient and caregiver considerations are also well covered. There's a helpful set of questions like, do they have access to the technology? What's their level of comfort with it? Do they have access to safe and private space for virtual visit? And do they need support for the use of the technology? And of course, and most importantly, it's made clear that patient and caregiver preferences should be prioritized whenever possible. To help choose the most appropriate modality, there's an excellent section on showing the practical benefits and limitations of each type of virtual care. Next slide. Choosing the virtual care tools that best suit the situation and making the best use of them is also well covered in the toolkit. For tech, for example, does it meet the required specs? Does it integrate with other health information systems? Is it easy for providers, staff, and patients to use? How well does it support standards of care and best practice guidelines? With regard to privacy, there's a thorough list of steps that can be used to help ensure that privacy is protected and maintained, like authenticating the patient's identity, getting proper informed consent, confirming that the patient's in a private space and being in a private space ourselves, using the tools properly so that they can provide the security that they're designed for, and lots of other tips on this. Workflow is a determining factor when it comes to whether virtual care works well or not. The toolkit has lots of great points to help with this too. Engage your team, find out about their needs and provide them with good training and support. Establish good processes and policies so it's clear who does what and how it should be done. And optimize scheduling for virtual care. Look at strategies for onboarding patients and ones that would work best and fit in your practice. There's lots of great tips that can make a big difference for providers and staff and patients. Next slide. Improving the quality of virtual care interactions leads to better experience and outcomes for patients and providers. So the toolkit includes recommendations to help prepare for and conduct virtual visits. There's also a much needed section on virtual physical exams. And frankly, this is all brand new. I didn't learn this in medical school, and not to reveal my age too much because it hasn't been around really that long. It's surprising how much can be done though. Through physician-guided patient self-examination. I've learned a lot in the last few years about that. And the toolkit includes some references to some excellent how-to videos and articles on this. There's a good set of important tips on safe prescribing while doing virtual care and to help ensure that the right meds are prescribed to the right patients in a secure and timely way. And of course, health equity needs to be a high priority, especially with virtual care. We need to recognize the potential causes of digital health inequities and have strategies in place to address them. We need to do what we can to make virtual care as equitable and inclusive as possible. Next slide. The toolkit emphasizes that to achieve this, we need to recognize and address the social and structural determinants of health of our patients. Next slide. The toolkit specifically addresses barriers like disabilities, distrust in healthcare providers, systems and technologies, lack of access to technology and data services, and issues with tech. Next slide. To help break through these barriers, the toolkit offers strategies at individual, technological, health system, and social structural levels. Done well, virtual care can improve health equity by providing access to care that wouldn't otherwise be available, and by offering patients more options so that they can choose the type of care that works best for them. There's lots of reasons why virtual care might be better for them for a particular visit. Next slide. The toolkit also includes a really helpful virtual care evaluation guide. We need to be able to properly evaluate the virtual care that we're providing. The guide helps ensure that we take this into account at a wide range of perspectives so that the results best represent the people being cared for. It lays out equity dimensions that should be included across the evaluation so that the data can be stratified according to equity indicators. And it reviews how being able to differentiate the results by modality can be more meaningful and more insightful. The guide also provides a helpful sample of evaluation measures and survey questions with key points and references about data quality, validity, availability, and collection, as well as ethics and privacy and security factors. Next slide. And the last section includes an excellent summary of each of the virtual care tools and resources referenced in the toolkit. Key points or pearls were collected from each of these references and really highlighted in the summaries. So this section is really helpful when you want to take a deeper dive into particular topics. Next slide. The Clinician Change Virtual Care Toolkit has helped me to better integrate virtual care into my practice. I'm more comfortable and confident with the virtual care that I'm providing. I've had lots of positive feedback from my patients, and they're appreciating the virtual care as much as I am. Whatever your role is, the toolkit can really help you achieve better virtual care. Thanks, and I'll pass it on.
Oops, we've got a bit of a preview there of the next one that's going to come up. And thank you so much, Kevin, for that presentation, for guiding us through that toolkit. And next slide, please. So now we're going to bring in David Kaplan from Ontario Health, Vice President of Quality, and he's going to tell us about Ontario Health's guidance for clinically appropriate use of virtual care.
Good afternoon, everybody. Thank you so much for allowing me to join. If you switch to my next slide, I guess the next one there is going to be my disclosures. So no financial relationships, but I do receive salary support from Ontario Health in my role as Vice President of Quality, and I'm a practicing family physician in Toronto. I'm going to start off by opening with a poll. And so maybe if we go to the next slide, we want to get a sense of whether or not the 72 folks on the phone are aware of the guidance that we published late last year. And I'll apologize for my voice. My allergies have gotten the better of me. This was my worst two weeks of the year when it comes to allergies. Great.
Yeah, we'll give folks 15 more seconds to vote.
Okay. Okay, so about half of you have not heard of them, and a quarter have read them, and another quarter know about them but haven't had a look. So hopefully more people will know about them after today and get a sense of the value in looking at them and some of the tools that we've included. So if we switch to the next slide, I'm just going to speak a little bit about why we developed these tools. So we knew that with the onset of the pandemic and the shift rapidly to virtual care, we knew that just from physician claim data that there was a lot of virtual care happening, a lot less in-person care. And of course, if you recall 3 years ago, we had all moved for the most part to this virtual first way of doing things, with trying to leave our offices open to be able to examine people and to bring the people in for other things that needed to get done. We worked with Inspire PHC to investigate really how primary care was delivering virtual care. And what we found was it really didn't, and you can see from the scatter plot if you understand it, but the takeaway is that it really didn't matter what payment model you were in, how much virtual care you did and how much in-person care you did. It actually depended on who you were practicing with. And so there were a lot of local contextual factors that drove the kind of practice you were doing when it came to virtual care. And what it did demonstrate was really significant variation in the delivery of clinical care. And my team does a lot of work in clinical and quality standards, and the areas we do quality standards are the areas where we have clinical variation that really isn't explained by anything other than variation. And so the idea of driving lack of variation to improve quality is where we start from standards. So if you go to the next slide, you'll see our general approach to guideline or standard development. We assess any current guidelines or policies. We don't develop new evidence. We synthesize the evidence. We do an evidence review. We look at data, and then we worked with an expert panel and onboarded them in a co-design process to guide the guidance. And again, this is not clinical practice standards. These were some guidance statements that we came up with. And then following that, we want to engage the broader stakeholder community in the planning of dissemination, and more importantly, in the communication and implementation efforts to get this into practice. So if you switch to the next slide, you'll see in the first phase of the work that we did, we built some foundational guidance. They're broadly applicable to community-based practice, but not specific to certain clinical conditions. We also created a bunch of supporting tools, 2 patient-facing tools that have been translated into 12 languages, and 1 clinician-facing tool. And the tools are available both in PDF and in a Word document so that practices are able to customize them for their own use. In my practice, we have a rheumatologist that sees a lot of patients who only speak Cantonese and Mandarin. And we had to do a lot of this work ourselves. I'll try to post in the chat an example of what we did on our website. We basically had to have a way for his new patients to learn how to use our virtual care platform. And so he translated the vendor's instructions into simplified Chinese, and we created a PDF and we've posted on our website. So really important to be able to explain to patients how to use virtual care. You can scan that QR code that's on your screen and get right to those products. Next slide, please. So we did a bit of a phase 1 evaluation. It was really early on. We released the guidance just before the new physician service agreement took effect December 1st, and we did a bit of an evaluation. You can see it here. For the people who did see the guidance, about half of them, or 40% of them, reflected that they were going to reflect on their own provision of clinical care virtually. And that actually 40% responded that they were going to ask their patients about their preferences after reading the guidance. And I think from an equity standpoint, that's so important. I know that I've had a patient of mine, I've had to change this individual's respirologist because him and his family could not negotiate not doing a video visit, and the respirologist for some reason didn't want to see him in person and didn't want to do it on the telephone. And so I think this idea from an equity standpoint of really trying as best as we can to navigate our patients and our clients and their family and caregivers preferences is really important to providing comprehensive care. The next slide talks really about phase 2 of our guidance. The ministry digital branch asked us to look at either additional specialties or specific conditions. And so we are looking at two mental health, 1 eating disorder, and depression and anxiety related conditions, and hypertension as well. We reconstituted the primary care expert panel, and we deliberated very specifically on hypertension guidance as an example, again, driven by a lot of work that came out halfway through the pandemic, and just looking at the top 25 reasons for primary care during the pandemic and the shift in those reasons in a high COVID region of Canada. Next slide. So I'll stop with what's next. So our approach to developing guidelines, as you know, includes looking at existing guidance and policies and the data state. We've reviewed that. Like I said, we've worked with the expert panel to co-design some hypertension guidance, and we're now right here in the involvement of trying to design and co-design tools and supports. And to really engage broadly with our stakeholder community. We know that hypertension affects Black Ontarians and Southeast Asian Ontarians differentially, and we want to make sure that we do broad stakeholder engagement as we work towards implementation support and adoption of the guidance. And with that, I'll end, and looking forward to questions later on.
Wonderful. Thank you so much for that, David. Next slide, please. So with that, we want to just take a few moments to help you understand how these tools can be used together. So we're bringing Kevin back, and he's going to share a bit of his clinical perspective on how, in practice, one might pull these tools together and use them to complement one another.
Excellent. Thank you. And I'll be brief. Really, to sum it up, the toolkit and the guidance document from a clinical perspective, the toolkit, it's a thorough general guide to virtual care, and it also includes the virtual care evaluation guide. The Ontario guidance document focuses in really well on appropriateness and specific conditions. They both have a practical focus, and they're based on solid references and advisory group recommendations. And they're produced by leading organizations, which really speaks to the content. Clinically, they really complement each other well. And I have found, and I think it's generally true, that they are best used together. These are synergistic. Most importantly, the toolkit and the guidance document, they're practical. They're practical tools that can help us provide effective, equitable and appropriate, safe and inclusive, efficient and timely, patient and person-centered virtual care. It's encouraging to see that they are familiar to some of you. If you haven't taken a look at these documents, whether you're a clinician or whatever your role is in healthcare, it's well worth your while. And if you have had a look at them, take another look, take a deeper dive. I think a lot of us have heard a lot of the points that were raised as examples today, and a lot of the points that are brought up in these documents. But it's really good to have a general overview to really help us fill in the gaps and give us some new ideas about how we can provide the best virtual care possible for our patients and communities. Thank you.
Thanks so much, Kevin, and thanks all of you for your presentations so far. And we're going to bring the spotlights up now on all of our panelists for our Q&A session. We've got about 15 minutes. So for those of you who have some questions on your mind, now's a great time to start typing. You've got the Q&A panel. It's like a couple of speech bubbles at the bottom of your screen. You can open that up, and then, if you see somebody else has asked the same question that's on your mind, you can go ahead and give it an upvote so we know that this is something that a lot of you are thinking about. If you would prefer to ask out loud, don't hesitate to raise your hand, and one of me or one of my colleagues will call on you. While you're thinking, I do want to get started with one question that has come in through the chat panel, and that's from Laurel. And Laurel is asking whether either of these tools provides guidance or resources to support integration across the continuum of care. So, looking at your interprofessional, clinical and non-clinical primary health care, as well as your specialist care, transitions to alternate levels of care, and so on.
I can respond to that from my point of view. And the the first example that comes to mind, and I think this is addressing the point that was raised, is it opened a lot of doors for me. I work in a family health team, like a CHC. It's team-based primary care, and what it allowed us to do was actually have group meetings. So it wasn't just the patient and the provider. So there were times where I would meet. We'd have a joint meeting with myself and the patient and a diabetes nurse, a diabetes education consultant, or a nutritionist, and we could have group meetings that we actually wouldn't have been able to have physically, but doing it virtually with video actually provided that opportunity that we could meet together. And also it gave us the opportunity in a similar sense that, you know, we could have patients' caregivers or other people that can help the patient with the visit, like someone that could help translate. So it really brought opportunities together that we still use now, even though we can do physical in-person visits. Sometimes there's still an advantage to doing even a hybrid with some physical and some virtual visits.
Thank you. And one question has come in through the Q&A. An anonymous attendee is asking, how are the social and structural determinants of health data collected right now in EMRs? And is this standardized? And I feel like Jen Rayner, you might be a good person to shed some light on this.
Sure, thanks. So within all of the Alliance members, we adopted the We Ask Because We Care standards we've collected the data since 2000. So we've been collecting socio-demographic and race-based data for about 20 years. But in 2012, we adopted the We Ask Because We Care standards that were rolled out by a group in Toronto. And so all of that data is standardized across all of our members. And it's interesting because I know Ontario Health, a different group, are working on some standards that they're rolling out across Toronto and Central OH. So there's lots of standards. I could share them with you if you'd like. I think the more we do this, the more we're able to understand any health disparities across different population groups. So I feel it's super important to do this, and it really enabled us to look at who was getting access to care and who wasn't getting access to care, and really ensure that tailored service delivery is offered.
Great, thank you. And we're seeing quite a few questions starting to roll in, but Kevin, I see you've got your hand up.
Yeah, actually, I'm keen to answer that. I think the Alliance has definitely led the way when it comes to collecting social terms of health information for their patients. They using things like the extended demographics form, because the EMRs were not designed to include anything really beyond sex, male or female, and date of birth and postal code. Some of the EMRs, like TELUS Practice Solutions, have just put in pronouns, but it's a very limited ability. So we've learned from that outside of CHCs, and now we're starting to implement tools like a health equity questionnaire, which can be filled out by providers or even sent to patients so that they can fill it out themselves, so that we can record this information, even prompt to ask about it, have a place to record it, and then be able to extract that information. You know, we need to know these factors if we're going to provide people with the care that they need the way that they need it. So it's good to see that this is becoming more standardized.
Maybe I'll just add something to Kevin's, you know, with my clinical hat on as well. The EMRs, one of the things we don't want to see is that people start putting things in fields that weren't what they were meant to be used for. And we've seen that happen in the past. So we have to be pretty careful as we think about, you know, working with the vendors to ensure that the right fields are available for, especially for our admin staff. I think a lot of practices that have gone through data conversion have noticed that that's been a real problem. And then the second thing that, you know, I've told some of my administrative colleagues about is that we have to remember that the vast majority of primary care practices don't have, you know, a lot of support for their admin staff. And when we look at jurisdictions that have introduced, you know, picking up much more demographic information, there has been an entire training and implementation plan for those admin staff to be able to ask the questions in appropriate ways to make patients and families feel comfortable. And we have to think about that as part of our change management plan for, you know, thousands of, mom and pop family doctor and small NP clinics across the province. And that's really important to make people feel comfortable to give us the information that we think we need to provide better care.
Thank you so much. We're going to move on to another question, which is, besides self-examination in virtual care, are there considerations for remote monitoring devices or wearables?
I can respond. We specifically kept remote monitoring out of our OH guidance. There's a separate piece of work happening around remote monitoring. And I'm happy to talk about my experience with remote monitoring. I did run a trial a number of years ago with remote monitoring, but I don't know if any of the panelists want to speak to it specifically first.
I can touch on it quickly. So we did call out remote patient monitoring in the clinician change virtual care toolkit. It was one of the areas that we looked at, because when we're looking at virtual care, we were not only looking at virtual visits, but also included considerations for remote patient monitoring, given how common it's becoming. So yes, it is included in our toolkit. I don't know, was there any particular question around it? Sorry, the question is no longer up, so.
Yeah, so the question was, the question was just what are there considerations for remote monitoring devices or wearables? So maybe would ask, are there specific challenges? Do they integrate better with virtual care? Are there specific things, maybe pitfalls? And Trish, if you want, or sorry, not Trish, Juliana, if you want to elaborate, feel free to raise your hand as well. We can unmute you.
And I can just add some more context based on my previous background, where I actually supported teams in implementing remote patient monitoring. I think one of the key pieces usually is also around that workflow piece, and how do you get the right information? How do you set it up? Because usually you're setting like alarms, or not alarms, alerts for setting areas when, depending on, if, for example, if it's cancer, that you have to identify, okay, what type of biometrics information do you want to be getting? So I find that it's the planning and actually identifying how you want to use it and how it needs to be integrated into the workflow is usually where the upfront work is. And then in terms of devices, you also have to think, do you have to provide devices to the patient? What does that need to look like if they have to return it? So it's usually more in that planning and setup phase that usually you need to put a lot more thinking into.
Thank you, Marinike. And so I'm going to just note here in the chat, Dr. Kaplan has mentioned a research paper about, the title is Health Coaching Reduces HbA1c in Type 2 Diabetic Patients from a Lower Socioeconomic Status Community, describing a randomized controlled trial. And so looking at how health coaching works with and without access to mobile technology, and how it can provide benefits. And Juliana has thanked Marinike for her comments and guidance, and also says she would be happy to hear about Dr. Kaplan's experience and research. So David, if you have a 30-second elevator pitch.
Yeah, 30-second easy. So this study was Noah Wayne's PhD at York University, really showed that health coaching, irrespective of the technology piece, was effective. The technology may have actually accelerated how well people reach targets. So that was kind of interesting. But in and of itself, like, it was neither here nor there. It was done at a CHC. And we did a separate study that we haven't published that used sort of more, not with NOAA, with Medley, where we actually gave patients weigh scales, blood pressure cuffs, and I'm trying to remember if we did anything with diabetes. I can't remember. But the technology, the managing the connection between the mobile phones and the Bluetooth technology was really, really problematic for our patients. And these were patients that had multiple morbidities. So they had CHF and COPD, or they had CHF and diabetes, or CHF and mild anxiety and depression. So we found it very, very difficult in the family medicine setting to just manage the technology and the running into problems that people had with the remote monitoring. But there are, yes, Karen, I was going to say there's a lot of experience with former OTN and success with remote monitoring. And thanks, Karen, for posting it in the chat.
Thanks so much. And Kevin, go ahead. I see your
Yeah,
hand.
I see the time. I'll try to be brief, but I can respond to a couple of questions that I see in the chat there. Jennifer asked about age and whether that affects the willingness for virtual visits. A couple of things. First of all, I was really surprised sort of mid into the pandemic. A lot of the grandparents are using their iPads to video chat with their kids, and they are actually quite comfortable with that. So that was really good to see. And for some people that really weren't familiar with that, to show them the technology has improved. You know, if you look at the studies that Jen was showing at the beginning, where people were reluctant to use video because of the technology, there's a huge difference between how easy it is now compared to how easy it was at the beginning of the technology. And it's really kind of cool and rewarding to help a patient in 30 seconds be able to do it, and they feel good that they're doing it. And then the other thing about age is I do a lot of secure messaging with more of the younger population. Also, they're used to texting. They don't talk on the phone anymore these days. They're all texting each other, and we can hook into that and provide them with care that they wouldn't otherwise be getting if we can, you know, do it in their world with secure messaging. And then to Marnie's question about you know, using virtual care to improve access to people that are unattached. Yes, you know, we've done that through projects with our collaborative at Health Crescents Canada. You know, we have connected communities without physicians to physicians, and we're looking at improving access to Northern remote Indigenous communities across the country using virtual care. So there's huge potential there. I just wanted to make sure we got that in. Jesse, I see you probably want to add to that.
Yeah, I was just going to jump in. I mean, currently, Healthcare Excellence Canada is supporting 41 groups from across Canada to consider what appropriate virtual care might look like. And many of the teams are actually using a virtual triage system where they've got emergency nurses who are answering phones, who are able to then direct patients to the correct type of service that they might need, be it virtual or in person. And it is supporting a lot of patients who wouldn't have a primary care physicians or would be considered unattached. And I think that, you know, this speaks also to how there was a question in the Q&A about adoption and how the toolkit is being used and how that adoption is going. And so certainly many of these teams are considering how they're going to develop and decide on appropriate virtual care based on use of the toolkit to help them make those decisions and help them move into that space.
Excellent. Thank you so much, both Kevin and Jesse, and for jumping in there and preempting some of those questions. So with that, we are at 1 o'clock, and going to do a quick wrap up. First of all, thank you all so much for taking the time to join us. Thank you to Jennifer, Marinike, Kevin, Jesse, and David for sharing your time, insights, and labor with us. Thanks to my colleagues Sarah and Wendy for expert technical and logistical help. And thanks to everybody for being here and coming with your questions today. I hope that you found what you've learned today helpful. You can find links to the resources you've just heard about, along with others, using the QR code and link that are visible on the left-hand side of the slide. And you can also take a moment, if please, we would ask that you take a moment to fill out the very short evaluation survey that will pop up when the webinar ends, or to navigate straight there using the QR code on the right-hand side of your slide. And the links to both of those will be are being posted in the chat right now. Please watch your inboxes with an email with a link to the recording of today's webinar, all of those resources, some of the other ones that were mentioned during the call, and so on, which should arrive on Friday, maybe Monday, because I am away at a conference right now. Thank you all so much for your help, and have a wonderful rest of your day.
Thanks for having us.